Hello and welcome again to another session of Cardiac Imaging Agora. In this session, we will go over cardiac PET and its utility in assessing inflammation and specifically sarcoidosis. This is a field that's still evolving. We learned a lot in the past few years about it, but one of the most important part of understanding this field is to be able to properly interpret these images to help our patients and help our physicians or referring doctors arrive at the proper diagnosis and thus proper treatment. So I'm going to start with a case. This is a 42-year-old male patient. He lives about 300 miles, almost 500 kilometers away from our institution. He was recently resuscitated from a cardiac arrest by a bystander at the restaurant, and he was transferred to a local hospital where he was found to have severe left ventricular dysfunction. A CT coronary angiogram was performed at that point at that facility, which demonstrated normal coronary arteries with no obstructions, calcifications, or anomalous coronary arteries. This is his EKG on presentation to the other facility. You can see here a patient having sinus tachycardia with a right bundle branch block morphology, some high voltages, but probably they do not meet criteria for LVH. This is his echocardiogram on presentation. You can see here clearly severe reduction in left ventricular systolic dysfunction in the four-chamber view, apical four-chamber view, with actually thinning of the basal septum of the left ventricle, maybe the basal lateral wall too. I will not belabor this point, but here you can see also in the apical two-chamber view, you have an additional akinesia of the inferior wall. You also have thinning of the basal inferior wall extending to the mid-inferior wall with significant reduction in LV systolic function. You can see also here in the apical inferior wall some area of thinning and hypokinesia. So with that in mind, the patient was referred to our institution after ruling out coronary artery disease as the most common reason, probably for cardiac arrest and systolic dysfunction. Cardiac sarcoidosis was considered in this patient an inflammation, and he was referred for cardiac PET. And as we've done in this series, we will go over the steps on how to, image by image and page by page, how to interpret a cardiac PET. And in this instance, in addition to interpreting perfusion, we will add the layer of FDG for inflammation. Before arriving to the lab, it's extremely important to be prepared and have the patient prepared for these kinds of tests. This is not your regular stress nuclear test. I will refer you to this very important, very brief 3-4 page document from the American Society of Nuclear Cardiology, a practice point on how to prepare patients for an image, for FDG imaging for inflammation, which is a little bit different from what we do when we're assessing for myocardial hibernation. So this is extremely important to go over and prepare these patients in this fashion. Otherwise, you will arrive at erroneous results or inconclusive results. So this is the standard fasting protocol that's used in most labs and advocated by the American Society of Nuclear Cardiology. A standard fast, prolonged fast of 12 to 18 hours. That's the most difficult part to comply with for the patients. And then to avoid any carbohydrates if possible. This says here high fat, low carbohydrates. Probably it's high fat, no carbohydrates is preferable in the preceding 24 hours. And then the use of heparin is again heterogeneous among different labs. At our institution, we use heparin, and I will show you how shortly. And then the patient is ready for the test on the day of arrival. This is more easy to comply with when the patient is hospitalized, like our patient here, because you can control all these variables. But when they're coming from home, it's very hard to understand and difficult to do. To go just and be honest about it, like most places outside the conference halls and lectures, it remains a challenge for all of us to arrive at good quality FDG images, PET FDG images, given the heterogeneous and unpredictable physiological myocardial uptake in most individuals, including normal subjects, which can reduce diagnostic accuracy, of course, of the test and result in misdiagnosis, improperly calling things as sarcoid when they're not. And this is an issue that for us and for others we've been dealing with at least for the past 15, 20 years since we started doing this kind of protocols for assessment of myocardial sarcoidosis. Now, with that in mind, we, Dr. Kremer, my colleague and friend here, and our group have come up with actually a very simple method to arrive at diagnostic imaging for these patients. And we have been using it at least now for over a year and a half with excellent satisfactory results, making repeat imaging, non-diagnostic imaging, a rare event at our institution where it was before that not infrequent, where we have to repeat the images to suppress physiologic uptake or bring the patients back, repeat the fasting, and so on and so forth. This is a formula, a baby infant formula prepared or made by Abbott, which is carbohydrate free. We give the patients this formula, and this is followed by 12 hours of fasting. This is a soy-based formula, and these are the contents here. Again, this is almost no carbohydrates present in this. You can, most hospitals have these formula. Actually, if you have a hospital with pediatric wing, you will find this formula available everywhere, and I have no conflict of interest as related to this issue. I don't have any stocks in pediatric baby formulas or soy formulas. So again, this Dr. Kremer came up with this, and we recently published this in the Journal of Nuclear Cardiology, results on a patient who was very frustrating for the patient, for us to get good images till we employed or deployed this method. Now we go to the images. The patient arrived at our lab. Again, in the standard imaging protocol, we review the transmission images and the emission images. Very often we perform rest-only images, especially if the patient has had a coronary angiogram or CTA showing normal coronary arteries. In general, we perform rest and stress, especially now that we're finding a lot of patients who have even normal coronary arteries have actually ischemia due to microvascular dysfunction, areas of inflammation. But in this instance, the patient arrived to the lab. He's had a CTA that has normal coronaries. So we went on and we looked at only rest and FDG images. So these are the rest rubidium images, proper alignment. The heart by perfusion images and by CT is well aligned. No other issues with the transmission emission images here. We move on to the next step, which is making sure we adjust the reconstruction images. On top, you're going to see the gated rest images. On the bottom is the perfusion rest images. So these are all perfusion images with and without gating. After we ensure that everything is aligned, we do the same thing for the FDG images on the bottom here. We make sure that we have them in sight and the zone or area of interest is captured. And then we process these images. So now on top, you're going to see the rest images. On the bottom, you're going to see the FDG images. And I'm going to spend a little bit of time on this one. Just to go over first rest images, I'm going to start with the vertical long axis on the bottom here, where you can see a significant perfusion effect involving almost the entire anterior wall, sparing the apex. Here in a non-coronary distribution, unless you have somebody with prior bypass or a lima to the LAD, where the apex is perfused and the proximal segments are not perfused. But in this instance, we know this patient has normal coronary arteries. So this is a non-coronary distribution of the perfusion defects. Again, if we move up to the horizontal long axis images, perfusion images, you can see that a severe reduction in uptake in the septum, in the basal septum specifically. And that's again reflected when you go up to the short axis images, where you can see these defects, these patchy defects in the anterior wall, in the basal septum right here, again in a patchy fashion. So now we turn our attention to the FDG images. Now, in the areas where we have perfusion defects on the rest images, we can see intense FDG uptake in these areas. Again, pay attention to the vertical long axis, bottom row images here, intense FDG uptake. If you go to the vertical, to the horizontal long axis images, again, the areas that have a perfusion defect on the rest images now, what they exhibiting is increased FDG uptake here. Again, this same pattern is seen in the short axis images. Again, this is a very interesting and important pattern to recognize and to go over very slowly and not to rush it through. Now we look at the standard polar maps. On the left-hand side, you're going to see the rest images, where again, as I've described to you before, you can see these perfusion defects in the anterior wall, basal, mid, and apical, sparing the true apex. And again, perfusion defects seen in the anterior septum at the base and basal mid-inferior septum. In a similar fashion, if you remember the echocardiogram that I showed you, where you can see that same thing. Now, if you look at the PET images, now we have almost the pieces of the puzzle missing from the perfusion images now are completed by the FDG metabolic images or inflammation images, where the areas that have a perfusion defect now exhibit intense FDG uptake. And I would venture to say the FDG uptake goes even beyond the areas of the perfusion defect, such as the inferior wall right here, where you can see FDG uptake, or the anterolateral wall right here, where you can see FDG uptake that is not completely matched by a perfusion defect on the rest images. The next set of images, of course, is the gated images. You can see this is a very poor ventricle. Ejection fraction is 24%, a dilated ventricle too. Again, the RV is dilated in this instance here. And we can see segmental wall motion normality in addition to the global severe LV dysfunction. Severe dyssynchrony, significant dyssynchrony of this left ventricle, despite the fact that when we look at the QRS, it shows only a narrow, relatively narrow right bundle branch block. So again, pay attention to these things. It will be useful for this case and for other cases. In case we have done rest and stress images, we traditionally report myocardial blood flow unless the LVEF is severely reduced because of the lack of data on myocardial blood flow in these cases. Then we go to review the CT images. Now this patient has had a prior CT for the heart to look at his coronary arteries, which was normal, but in case they did not have that, we look for calcifications in the coronary arteries to suggest presence or absence of coronary disease. And in this instance, you can see in addition to no evidence of coronary calcification, you have now significant pleural effusions bilaterally in this young 42-year-old male patient, indicating significant heart failure. Now, to generate a meaningful report, these are the list of diagnostic or diagnoses we have in our lab or indications for stress testing. And you can see here at the bottom, this patient will fall under the category of assessment of suspected cardiac sarcoid, since we don't have a confirmation of cardiac sarcoid by either biopsy or other methods. So this is assessment of cardiac sarcoid rather than known cardiac sarcoid. And then we talk about what we have done and when we have done it. And again, you can see here the dose of rubidium we've used at rest, the FTG we've used at rest, what was the resting glucose, how much heparin we've used, and what was the fasting duration for this patient. All these are important for quality assurance and going forward, so we can, if we want to figure out why we have a problem with the test and why the quality was or was not good, we can end up basically interrogating that and figuring out if there is an issue here. Now, again, this is the standard clinical report where we have the presentation of the patient, height, weight, medications, and if they have done a stress test, let's say they've done a pharmacological stress test, in this instance, we'll fill all this part here. We report the left ventricular function, volumes, systolic and diastolic volumes, and then we report our general impression of the right ventricular function, which in this instance was moderately dilated and moderately decreased. Then we go to the coding of the images for perfusion, as we've done in prior series in this on cardiac imaging Agora, or we do it in clinical practice. We use a 17-segmental model, and you can see here reflecting severe perfusion defects in the anterior wall, in the basal anterior septum, basal and mid-inferior septum, and some patchy issues here with the inferior wall. This is PET images. They're all attenuation corrected, good quality. And if you have any defects, you should be calling them and not attributing them to attenuation. Attenuation is rarely, if ever, an issue with PET imaging. Then we display the same images I showed you before, the rest images on the segmental 17-segment model next to the FTG images, again on the 17-segment model, to show you the complementary matched FTG uptake, where you have a perfusion defect here, and now you have FTG uptake matching those perfusion defects, indicating, in this instance, inflammation. Now, the American Society of Nuclear Cardiology suggests the way we read these scans in the following fashion. So if you have no FTG uptake, that's absent. If you have diffuse FTG uptake, and they often attribute that to poor dietary preparation, we don't have this issue in this case. Focal FTG uptake, which is the case here, where we can see comfortably we can report this as active inflammation. And you can, in poor images where the dietary preparation was so-so, you can have diffuse FTG uptake, which is faint, with some areas of intense FTG uptake reflecting active inflammation. Now, as far as reporting inflammation, again, we report it in the same fashion advocated for by the American Society of Nuclear Cardiology. We report there is evidence of active inflammation. We code the segments where the inflammation is, and that's extremely important, because what you want to do is, especially if you start doing serial imaging on these patients after you start treatment, you can actually compare apples to apples. So the idea of reporting inflammation without the segmental part of it is obsolete, and I don't advocate doing that. You should report it in a segmental fashion, especially if you start having areas of inflammation, areas of scar. So you have to do that so you will enable future follow-up and future comparison of improvement or worsening of inflammation and scar. In this instance, we did not have any areas of scar. Areas of scar will have defects at rest plus no FTG uptake. So in this instance, we did not have that, because we created these cutoffs for large areas of inflammation. So less than 3 segments will be small, between 3 and 5 will be moderate, and more than 5 will be large. We can debate that, but I think this is something we created here, and we've been comfortable with it. You can have different thresholds at your lab, as long as you all agree on them and read them in the same way, especially if you have multiple readers. Another important thing to do with these patients who are referred for cardiac PETs for sarcoid, cardiac PETs with FTG for sarcoid, is to review the images in a non-cardiac reading station. And then we use here Syngovia at our institution. This is used for oncology interpretation of images. In these instances, actually, the scaling of the image is much better. You can see the FTG uptake here, the patchy form of FTG uptake. Also, if you have extra cardiac uptake, you will be able to pick it up. So here's the cardiac uptake right here. And if you have any areas of, let's say, pulmonary uptake, mediastinal uptake, hilar adenopathy, liver uptake, splenic uptake, reflecting extra cardiac sarcoid, then you will be able to pick it up. So I advocate strongly that in every instance where you are reviewing these images, you review them in a non-cardiac station in addition to the cardiac station. Finally, of course, after this whole exercise, it's important to create a report that's meaningful to the referring physician. So this is an abnormal PET with no evidence of scarred myocardium. We have evidence of active inflammation. We said the inflammation is large when more than 5 segments. The FTG uptake was focal in these segments. We did not have issues with lack of suppression in the normal myocardium. And because of the LVEF and the active inflammation, this is considered a high-risk scan, and we did not see any coronary calcification on the CT done on this patient for attenuation correction. So this patient, before he arrived at our institution, actually has had a cardiac MRI at the other facility. This is one shot of the cardiac MRI. You can see here the delayed enhancement. Again, you can see it in the basal and mid-inferior wall. You can see the delayed enhancement that we saw in the anterior wall right here. But it's very hard from these images and the images shown here, again, reflecting this pattern of delayed enhancement, patchy delayed enhancement here, which is consistent with sarcoid, to comment about myocardial inflammation. So you're comfortable here calling these areas of patchy uptake probably scarred myocardium. But as we have seen from the PET images, these were not areas of scarred myocardium, but rather these were areas of inflammation. So MRI is exquisite and a good technique to identify this form that's consistent with sarcoid. But I think its role in identifying scar versus inflammation is still to be seen. So in conclusion, PET for inflammation and sarcoid, I think the most important first step is not to have a patient in your lab to rule out cardiac sarcoid before they had a good evaluation to exclude coronary artery disease. Very often we have patients referred to us for sarcoid. They've never had assessment of the coronary anatomy, and we find out that they have coronary disease. So this is not something you want to path you want to go down, especially if you start treating for sarcoid when the patient has had obstructive disease, and that's not the disease you should be treating. The other issue is to review whatever data available to you before you read the images. If you have EKGs, look at them, as we've done in this instance. If you have an echo, look at the echo. It's extremely helpful that you look at the images side by side and inform yourself, and if you have trainees with you, to inform them. And finally, if you have MRIs, if you don't know how to look at them, find a colleague that can show you how to look at them, and try to find a partner in MRI. At our institution here, we often call each other, look at these things together. It's extremely important to get to the correct diagnosis, because these are probably the toughest patients to assess perfusion, inflammation, scarring, and all the other variables. Patient preparation and fasting is extremely important. Otherwise, you'll end up with a bunch of non-diagnostic tests. Again, review the images systematically from the rest images, stress images if available, blood flow, the contribution of reduction of myocardial blood flow to or inflammation to myocardial blood flow impairment is still to be studied and published, but that's an area that's probably will be hot in the next few years. Review the FTG images in the cardiac software as well in oncology software, so you can assess FTG uptake in the heart in a scaled fashion, appropriate for the image, as well as extra cardiac uptake, FTG uptake, sorry. And then finally, generate a consistent report with segmented description of the areas of scar, inflammation, or normality. Keep in mind the Japanese criteria and the Heart Rhythm Society diagnostic pathways for cardiac sarcoid. So let's talk about our patient here. This is a patient who came with an aborted fatal ventricular arrhythmia or sudden cardiac death. So probably he fits this major criteria here. He has basal thinning of the ventricular septum as was seen on the echo and the MRI. He has a left ventricular contractile dysfunction that's not explained by presence of absence of coronary artery disease. And then he has FDG uptake in the heart, again, in areas suggestive of inflammation. MRI also showed the same delayed enhancement in the myocardium. So he probably has met all these major criteria from A to E. Now, as far as the minor criteria for this patient, this is patient actually during monitoring, he was found to have frequent ventricular arrhythmia. I did not show you that. He has a right bundle branch block, as I've showed you in the EKG. He has perfusion defects in this instance on a PET. It doesn't matter if it's PET or SPECT, he has perfusion defects. Now, he did not have an endocardial biopsy, but he meets all the major criteria and 2 of the minor criteria for cardiac sarcoid. So this is, again, important to refresh your memory when you're looking at these images and go through this exercise. That way you enhance your own sensitivity and specificity, and you benchmark yourself against these criteria every single time you read these scans. With that, thank you so much for listening to this edition of Cardiac Imaging Agora, and hope to see you again in the next session. Thank you.